Welcome to More Fun with Farm. Today's topic is inflammation, part 1 of 4, overview of inflammation and histamine. The accessible objectives for this mini lecture include identification of histamine receptors and their actions, a brief outline of the biologic pathways for histamine synthesis and degradation, and predict adverse effects of antihistamines comparing and contrasting first and second generation agents. Drugs in this mini lecture include cromolyn, the first-generation antihistamine diphenhydramine, also known as Benadryl or Sominex, and the second-generation agents cetirizine, Zyrtec, and loratadine, Claritin. While the accessible objectives for this mini-lecture don't include the prostaglandins, we're still going to be studying the background for all of the things that are related to inflammation. So we'll talk about cyclooxygenase, lipooxygenase, and some of the products like leukotrienes and prostaglandins. We'll soon talk more in depth about the terminology of prostaglandins and how they're named. This chart provides a summary of the inflammatory effects of eicosanoids. Some effects are anti-inflammatory while others are housekeeping functions. This chart depicts how eicosanoids are involved in the cardinal signs of inflammation: rubor or redness, tumor or swelling, calor or heat, and dolor or pain. By the way, eikos is from the Greek term for 20. The eicosanoids contain 20 carbon atoms. They're derived from fatty acids of the cell membrane. As we saw in the hematopoiesis lecture, the chemical milieu prompts cellular development and cellular function. For normal immune function, we need both stimulation of inflammatory response, but we also need resolution. This graphic represents the onset of inflammation in red, activated by derivatives of arachidonic acid like leukotriene B4, prostaglandin D2, PGE2, and also cytokines like interleukin-1 beta and TNF-alpha. The impact of these factors is seen in the upper portion of the graphic. As inflammation continues, we begin to see cytokine-induced increases in adrenocorticotropic hormone, ACTH, and we see downregulation of further cytokine release that promote the onset of resolution, seen here in the yellow middle portion of this graphic. At red and green, we see resolution, also stimulated by fatty acid derivatives like lipoxins, myrisins, and resolvins that we'll soon talk about more. Note that interleukin-10 and transforming growth factor beta are anti-inflammatory signals. Inflammation and clotting are pretty closely related. Let's talk about some of the players. First of all, histamine. Histamine does have a direct impact on blood clotting. It's going to increase gastric acid secretion, as we'll soon see. It causes blood vessels to dilate, bronchioles to constrict. It's going to increase vascular permeability at the level of the capillary to cause tumor or swelling. It's going to increase release of adrenaline, also known as epinephrine, which is going to increase the heart rate. So overall, from histamine release, we see swelling and inflammation. One of the inflammatory substances that we probably don't think about as an inflammatory substance is serotonin. It's going to increase platelet activation. It's going to increase vascular smooth muscle cell synthesis of inflammatory cytokines. It's going to activate the endothelial cells, kind of disrupting their integrity to allow for capillary leaking. It's going to activate basophils, mast cells, eosinophils, lymphocytes, neutrophils, monocytes, macrophages, and dendritic cells. Arachidonic acid derivatives include prostanoids, prostaglandin and prostaglandin-like autocoids, leukotrienes, and other derivatives. Upon certain inflammatory stimuli, phospholipases like phospholipase A2 can get activated. As lipases, they'll liberate a fatty acid from the membrane phospholipid. In the case of phospholipase A2, the fatty acid released is arachidonic acid. Different cell types possess different enzymes that convert arachidonic acid into precursors of the prostanoids, leukotrienes, and other lines. Which final product is formed from the precursor depends on the cell or tissue specific enzymes that are present. For example, platelets express thromboxane synthase, which leads to formation of thromboxane A2. The inflammatory and anti-inflammatory effects of these final products were discussed in the previous slides. Molecules in the kinin family include substance P, P for pain, bradykinin or BK, calodin, and high molecular weight kininogen prekallikrein. These molecules cause pain, intensification of the prostaglandin, serotonin, leukotriene cascades, they increase cytokine expression, and they're involved in the activation of the clotting cascade. Cytokines play an important role in both activation and resolution of inflammation. Clotting factor 12A increases activation of prekallikrein and high molecular weight kininogen, while thrombin, also known as 2A, increases cyclooxygenase 2 activity, formation of prostaglandins, formation of platelet activating factor, and increased activity of inflammatory nitric oxide synthase. Nitric oxide, when formed from inducible nitric oxide synthase, is cytotoxic, and it can increase formation of reactive oxygen species to increase vascular leakage, chemotaxis of immune cells, and increases in nuclear factor kappa B. It's not so important to memorize all these details, but it's more important to get an idea of the players in the game and how complicated their interactions really are. The first inflammatory player that we want to talk about and focus on is histamine. This slide depicts its biochemistry. Histamine is formed from histidine when histidine, the amino acid, is decarboxylated by histidine decarboxylase, which, for your information, is a vitamin B6 or pyridoxine-dependent enzyme. Histamine itself undergoes degradation by two pathways, N-methyltransferase, then monoamine oxidase B, or degradation by diamine oxidase and subsequent addition of ribose. This slide summarizes the effects of histamine receptor activation and/or antagonism, which is actually inverse agonism. Items in bold are of particular pharmacologic importance. Notice that histamine itself causes watery, itchy eyes, runny nose, and sneezing, so antihistamines, technically histamine inverse agonists, like diphenhydramine, Benadryl, and loratadine, Claritin, help reduce these symptoms. Histamine promotes wakefulness, satiety, and memory, so antihistamines that penetrate the brain can cause sedation, confusion, and weight gain. The histamine H2 receptor in the GI tract increases gastric acid secretion, so our histamine H2 receptor inverse agonists are used to treat peptic ulcer and heartburn. There are four primary pharmacologic targets for histamine. First, for your information, we can inhibit formation of histamine by inhibiting the enzyme histidine decarboxylase. Catechins like epigallocatechin gallate from green tea can decrease formation of histamine. We can inhibit degranulation of the mast cell, the prescription drug cromolyn, Intol, and for your information, the Egyptian herb Ami Visnaga, also known as Kella, has an active constituent kelin that can similarly prevent release of histamine. Most commonly, we use inverse agonists, antihistamines like diphenhydramine, as direct antagonists of the receptor to reduce the effects of histamine. Finally, we can use physiologic antagonism by giving things like epinephrine and/or glucocorticosteroids to reverse anaphylaxis or treat allergy. Here we're looking at the mechanism of blockers of mast cell degranulation. They actually block these calcium channels that lead to exocytosis of histamine. They carry a charge at physiologic pH, so there's minimal systemic side effects, but there's also minimal systemic absorption, so we have to put them where we want them, insufflating into the lungs for asthma, into the nose for nasal allergies, or as eye drops for ophthalmic allergies. These guys have to be given before histamine release because it's kind of like closing the barn door after the horse is out if you give it after the reaction already happens. So they're not as needed PRN drugs. They have to be used around the clock before the allergic reaction actually occurs. The most common target for histamine is right at the receptor. We use antihistamines, which technically are inverse agonists. This slide shows a lot of detail about how the inverse agonists work. In A, we can see the H1 histamine receptor exists in two conformational states, inactive and active. They're in equilibrium with one another. In B, we're seeing where histamine is binding preferentially and stabilizing the active state, while our antihistamines, the inverse agonists, bind to the inactive state to stabilize it in the inactive state. The bottom line is it turns off the actions of histamine when we use histamine inverse agonists. And finally, one of the most important things, the differences between first and second generation antihistamines, which are shown in red in this slide. The biggest difference is that our first generation antihistamines penetrate the CNS to produce drowsiness and increased appetite. They also possess significant anti-muscarinic effects. So we see anti-SLUD, dry mouth, dry eyes, decreased urination, constipation, maybe some tachycardia, and mydriasis, which can be bad in patients with increased intraocular pressure from glaucoma. Our second generation agents like loratadine, which is Claritin, cetirizine, which is Zyrtec, have less CNS penetration, so they cause less drowsiness, less weight gain, and they don't block the muscarinic receptors. They can prolong the QT interval, though, and predispose patients to arrhythmias. Finally, just a brief word about the histamine H2 receptor antagonists. There are three primary signals for increased gastric acid secretion, one being acetylcholine at the muscarinic M3 receptor, the second being cholecystokinin or gastrin at their receptors, and our topic now, histamine at the H2 receptor on the enterochromaffin-like cells. All three of these signals can increase activity of HK-ATPase to increase proton secretion into the fundus of the stomach by the parietal cell. So H2 antagonists like cimetidine, Tagamet, famotidine, Pepsid can be used to reduce acid secretion by the stomach.